today, and I'm going to attempt in about 45 minutes to cover some studies I've been working on over the last 15, going on almost 20 years that attempt to bring evidence-based recommendations on obesity prevention to communities at large. And my work is really focused on trying to engage communities to embrace the work that many of us have done in laboratory-based settings or in very small controlled trials, and we know that they would be effective if brought to a larger population. But the challenge always lies in how to get these excellent recommendations that work in controlled settings into the real world. So that's what I've focused a lot of my time on. So I know a lot of people in here work on obesity, but just so everyone knows why I'm spending a lot of time on it, you know, we have an epidemic in the US, and these are NHANES data really just showing us the dramatic rise in obesity over the last few decades. And so in very young children, the rates of obesity have doubled since the 1960s. They've more than quadrupled in the elementary school age population, and they've tripled in adolescence. And my work has primarily focused on elementary school, so 5 to 12-year-old children. And we also know that rates are disproportionately associated with a number of things, including race, ethnicity, and also geography, and of course, income status, and newness to the United States. So I've addressed a lot of these disparities in my work, but just pointing out non-Hispanic white versus non-Hispanic black, and Hispanic children, the rates are quite different. And you've also probably heard that we've seen a plateau in obesity nationally, which is very good news, but the plateau really doesn't represent the increasing rates in many minority populations. And even some of the community-based work that's been done, either at the community or even the state level, has been very encouraging. But you probably have also heard that the only place that disparities were really impacted were in Philadelphia, and also we showed some of that in Somerville. But some of the work that's being done is not really reaching the hardest to reach populations. So we still have a lot more to learn with taking these evidence-based recommendations and bringing them to the populations in need. So I've been doing community-based, community-placed nutrition and intervention studies now, as I said, for almost 20 years. And this is just a nice timeline of some of the projects that I've either led or been a co-investigator on, funded by NIH, CDC, Robert Wood Johnson, as mentioned. And I've learned a tremendous amount. And I was saying before I started the talk, when I was working on this, I thought I could just give a talk on lessons learned, really what I've struggled with over the past couple of decades, really trying to impact the population at large, and the sleepless nights, sending people into dangerous communities, and having data really impacted by unexpected things when you do this type of work, and really trying to pull together teams of people who often don't have the right experience, but yet they are able to work with the communities that you're engaging. So it's just a lot that I could talk about, and it's not what I'll focus on today, but I'm happy to go into detail in any of that for those of you who are able to come to lunch. So I'm not going to talk about all of these today. I just picked a few that, you know, I have some data that's been published that I could share that just gives you a sense of some of the findings that I've been able to publish and disseminate doing this work. So first I'll talk about Shape Up Somerville. This is still near and dear to my heart, mostly because when I was writing the grant with my colleagues at Tufts, very, very close colleagues, someone that Whitney has worked with for years, Aviva Must and Jean Goldberg and Mim Nelson, I actually wrote those goals to examine the effectiveness of the model of trying to catalyze an entire community and prevent unnecessary weight gain, and also to transform a community and form social change at the national level. And this seemed pretty ambitious, and also to get funded by the government. And people really didn't think we were going to see a biological effect by working at the community level and trying to engage multiple stakeholders within the community. And more importantly, we were putting together a portfolio of initiatives. So as most of you know, it's desirable and pretty clean to pick one particular strategy and implement that in a controlled fashion and then look at the outcome where you control everything else around it. But I felt like it was time back over a decade ago to really try to put together a package of interventions that we knew were effective based on controlled trials. So decreasing television time, increasing fruits and vegetables, increasing the minutes of moderate to vigorous physical activity. And when you go into the community, just doing one of those didn't seem like we were following the recommendations of what we wanted the population to do, but we really needed to combine things and develop a package of interventions that could be brought to children. Now you can imagine the complexity with that, getting them to all work synergistically, but also in the end being able to say which one was more impactful than the other, or which of those interventions or the dose of the intervention drove the biological impact. So this study really wasn't designed to answer that question. Some of the work I'm doing now using system science and even agent-based modeling is enabling me to do that a little bit better. But back when I designed this, it was, does this package of interventions really have an impact on children's health? So this was a 3-year controlled trial focused on 1st through 3rd graders in an intervention community, Somerville, and 2 matched control communities. And this was the intervention. It looks complex, and that's because it was, but we were really focused on energy balance. And at the time, I did some calculations to give me a sense of what we should be aiming for. And I came up with about 125 calories. Now, that was not sophisticated modeling that has since been done and published. And that number is more like 150 calories in terms of the energy gap that we need to address to bring the obesity rates back down. But nonetheless, it was pretty good back of the envelope calculations. So what we were striving for was to impact 125 calories a day. And that meant by improving the quality of foods and decreasing the intake and increasing the output. And so this package of evidence-based strategies was implemented within the community before, during, and after school, using reinforcing communities of the home and the community at large to, again, impact energy balance, but to make sure that the children and the parents were hearing the same messages from the media, from the pediatricians, from restaurants, as they were getting in the more structured environments like school and the after-school programs. And in a community like Somerville, many children attend after-school programs, so really we had them from 8 in the morning until 6 at night, and we're able to implement this package of interventions. So I'm just going to show you some visuals, but you get a sense looking at this: school meals, recess time, after-school programs, safe routes to school, etc. So it was really impacting the entire community. So within the home, we were trying to reach the parents, the children, the entire family. And here's a walking school bus, and that was going on throughout the entire community. And we used GIS to really develop the safest routes to school and disseminated those maps to all the families. In the school, we impacted the children, teachers, administration, and staff. So there were many things going on, from professional development to the development of a curriculum that would be implemented in every 1st through 3rd grade classroom over a 2-year period, to working on policy change with the administration and even staff wellness programs. And here's just an example of a food service provider working with whole food and a child eating a healthy school lunch. Within the community, we worked with all of the major after-school programs, and there were about 14 at the time. So that includes YMCA, Boys and Girls Club, school-based programs, where most of the kids were going. And then we worked with the ethnic groups in the community, and this will become important in a moment when I tell you about a follow-up study. So Somerville is a gateway community. A lot of new immigrants are there, and in order to reach many of the individuals and parents and children, we had to work with the community groups who serve those individuals. So the Brazilian Women's Coalition, the Haitian Coalition, etc. So we really engaged them from the beginning. And then we worked with restaurants in the community. They weren't chain restaurants, they were independently owned restaurants. And here's an after-school program where kids were doing yoga. Here's the mayor eating out at one of the Shape Up approved restaurants that we worked with. And here's some kids at a community event. And then we worked with the healthcare system. So we trained every pediatrician, family physician, and their whole nursing staff on the new BMI guidelines, which had just come out when this study was ongoing, in order to classify, refer, treat children who were presenting with overweight and obesity, and most importantly, from our perspective, to help families prevent the onset of overweight and obesity. So that was a pretty aggressive undertaking to train everyone in the community. But again, they were reinforcing the messages that the children were getting elsewhere. And then we work with local government, because if you only focus on the schools, and even the schools in the home, as soon as you let a child loose in the community, a lot of damage can be done. So you really have to make sure that the entire community is on board with policies within the community that support and reinforce health. And that's just an example of the mayor at a built environment training that he then went on to institute within the entire city with a paid pedestrian and bike coordinator, for example. And lastly, we work with local media. So in this case, it was the Somerville Journal and some of the local cable access television. So this is the way that we disseminated all the evidence-based strategies. So I'll just give you some outcomes of the study. We did, I think, a pretty good job with retooling school food service, and this ended up as its own paper. But the outcomes were an increase in foods that we'd recommend based on the dietary guidelines, an improvement in attitudes of student, parents, school faculty, and the food service staff, policies regarding food service. And just to give you a quick example of that, there was a renegotiation of the union contract. So it seems simple to say, well, if you have a staff of food service providers, you just tell them they have to actually cut vegetables up and cook them and serve them. If it's not in the union contract, it can't happen. So the whole contract was renegotiated, and it actually stated that they would prepare and serve whole foods. Because before that, they really only needed to use can openers and box openers and just use the food that was coming to them from the government program, which isn't all bad, but it really doesn't look quite the same as you know when you put it on a tray than the fresh salad that I showed you was being prepared. So that was a pretty significant undertaking, as well as increasing the produce budget by like tens of thousands of dollars. A lot of money went into it, and connecting with local agriculture. And I'd say the biggest thing we did is we purchased equipment. So they didn't have any way to prepare whole foods. So they had box openers and, as I said before, and can openers, but they didn't have knives and industrial size food processors and mixers and things that you'd need really large industrial size to actually provide the food to the children. And that's the result of changes in our government policy through the USDA and Department of Ed in the 70s, when they actually stopped funding that. And that's when cafeterias went to just heat and serve or open and serve. And so now the movement, as you know, is to bring whole foods back, but it requires outfitting entire kitchens. So this was just an experiment where we tried to actually make that happen. And teaching people how to use knives. When people are hired for food service positions, they're not necessarily skilled in knife use and safety. So that was a lot of the training. So in order to actually serve those fruits and vegetables to children, which is a dietary guideline, you need to step pretty far back in the system to make that happen. And that's a lot of the work that we did. So I'm pulling out a couple examples to talk in more detail about that were incredibly time consuming and required a lot of engagement and trust building. And this is what the a la carte looked like before, and this is the a la carte after. That should be every a la carte in schools across America now, almost 15 years later. And then we had this restaurant initiative that now with menu labeling happening, hopefully most restaurants will look like this now, but we wanted to make sure people knew what they were getting and that they had good options. So we worked with restaurants to become Shape Up approved, where they had smaller portion sizes, fruits and vegetable, low-fat dairy, and we really worked on their concerns about the barriers to overcome serving these things, and we worked very closely with them. And this became its own manuscript as well, which a lot of people are referring to as the whole restaurant industry is trying to move toward healthier food. And there was an announcement yesterday, I don't know if anybody caught it, about Subway. It's pretty exciting. It's part of the Let's Move and Partnership for Healthy America initiative, but Subway committed over 3 years for every children's meal to be less than 600 calories and to meet federal guidelines for like school lunch, and to default beverage to non-fat milk and water, and to aggressively push apples as a side. But here's the exciting part, a $40 million campaign called Pile on the Veggies, which is the hardest thing to get improvement in with kids. Fruits are a lot easier. So when kids enter Subway and they order, they'll be encouraged to get lettuce and tomato, and to be honest, I don't know, pickles and banana peppers, whatever the vegetables are. I don't go to Subway that often, but I know there's a bunch of options. And they'll rigorously evaluate this, so that'll be pretty interesting to see if they can move vegetable intake through a fast food establishment. So there's a lot of good work going on. It's not perfect, but it's definitely moving in the right direction. So we did some early work thinking about this kind of stuff. And there's the mayor who went around and ate at all the restaurants. Okay, so what happened as a result? So I'm going to show you the BMI Z-score data, which is really the most important data in terms of demonstrating that we had an impact on weight status in children. So of the children in the intervention and the control communities, we measured their height and weight in triplicate at 4 time points, before and after 2 school years. So you see fall 03, spring 04, fall 04, spring 05. And what I want you to really focus on is the line that says combined controls. And let's see, I don't want to push the wrong button. There we go. So that's this line right here. So that is the combination of the 2 control communities together, which a priori is what we intended to do. You can also see each control individually. But if you look at the combined controls versus the intervention, you can see a decline in BMI Z-score over the first year compared to the controls. And then you see this horrible change here in the summer, which led to a whole other research study that was led by Alison Tovar, who's at URI, and Aviva Must, who's at Tufts, looking at the impact of summer in low-income children. The truth is, when school ends, childcare ends for a lot of low-income parents. And to afford a comprehensive summer program is really expensive. It can be thousands per week. So a lot of kids stay home in the summer, and our results showed they watch a lot of television and they consume a lot of calories. And here's the impact. An increase in BMI Z-score. That's a whole other area we could talk about, but unfortunately it happened even in the intervention. But then in the second year, we were able to see a decline again in the BMI Z-score. So from beginning over here to end, it was actually a decrease in BMI Z-score compared to an increase in the combined controls or either control independently if you look at those. And so we've published 2 papers looking at this, demonstrating the decline, which you see here, a negative here and a negative here, in over 1,000 children in the community. So that had never really been done before, again, at the community level with a package of interventions in a very disadvantaged group of children. So that really led a lot of people to think about taking these evidence-based strategies and really trying to get them out there into the real world in using dissemination science and scalability models and making sure that we stay rigorous as we do it, but that we get it to more children than we do in controlled trials. And then the first year results that were published were translated into pounds. So people, fortunately, the editors asked for this because people really wanted to know, what does negative 0.0 BMI Z-score mean? So what we're able to show here is we prevented about 1 pound of unnecessary weight gain. And for those of you who don't study body weight, kids are growing and you don't want to prevent weight gain, you want to prevent unnecessary or undesirable weight gain. So for a typical 8-year-old, which is what we were looking at here, you would expect to see them gain about 6 pounds a year. This was looking at 1 school year. That's why you see the number a little lower here, about 5. About 6 pounds a year. What you don't want to see is 10 pounds per year. So that 4 additional pounds of unnecessary weight gain is what you often see in children, and compounded over time, they graduate from high school obese. So we're trying to prevent it each year, year after year, and our results showed that we prevented about 1 pound. It does sound very low, but spread that out over a population and multiply that by 12 years in the system, you could actually end up with children who are overweight, obese versus not. And I don't have the prevalence, incidence, and remission data to show you today, but in the second paper that we published, we did look at those findings, and we actually did see an impact on remission. So kids who started the project overweight and obese, in Somerville, there was a decline in the percentage of kids who ended the project overweight and obese. So that was pretty positive and more meaningful when you put it into weight category versus pounds or BMI Z-score. So we just published some of the behavioral data because people want to know, well, what led to that BMI Z-score change? Obviously, you made environmental and policy shifts, but what happened at the individual level? So we had individual behavioral change in the children, and this is what we found: a decline in sugar-sweetened beverages, an increase in sports and activities, and a decrease in total screen time. So right there you can see a meaningful difference in behaviors that directly impact energy balance, which is exactly what we set out to do. So I learned a lot from this study, and I ended this study feeling like, wow, this was great. It was successful, and papers were being published. There are several others that we have that have been published with the outcomes and learnings of this study. But most importantly, it got picked up by the press. And if you've ever had research that's been picked up, you know that you start getting calls from everybody, because as academics, our names and emails and phone numbers are public. So people can go from, in this case, the Wall Street Journal to the Tufts website. And that morning, the phone call started. And there were people from communities all over the country, public health leaders, parents, principals, policymakers saying, how can we get this in our community? You found these great outcomes. The Wall Street Journal picked it up. And we want that to come here because we have an obesity problem, too. And as a scientist, that's pretty challenging. That's not really what I'm funded to do. And yet, just giving the findings to the public health departments across the country, there's a gap there. It's not that easy to take our scientific findings and say, without $2 million, which is what this costs, go ahead and try that in your community. So it was challenging, and I've struggled a lot over the years with how to actually scale this work up, and that's where I'm going to actually end my talk today, because I'm starting to do some of that. But part of it is you feel responsible. You have these great findings, and you've taken government money to do them, and you have a team working on it, and you know there are kids who need it. And what do you do with that? You publish it in a peer-reviewed journal, and then you just kind of cross your fingers that something else will happen. So I've done part of just continuing on with rigorous science and part of trying to get the findings into the real world, and that's kind of the intersection of my career at the moment. But here are some of the things that I learned. Leadership matters a lot. Leadership at the high level and leadership down at the grassroots level. They both matter a lot. You need local data to catalyze support. So anyone who's had seed funding and starts to collect some information, whether it's qualitative or quantitative, it helps a lot to then make the argument in the community. Here's the problem with data from your community, not NHANES data, but in Providence or in this neighborhood in Providence. And I'm sure many of you have done that. And we did it as well as doing key informant interviews and focus groups to build relationships and to really understand what would work in that community. We had early adopters, which are really important, a lot of professional development. So I gave talks to the food service providers, who are primarily women without a high school education, many immigrants who really cared about the kids, but also wanted to know, how can I be healthier? What can I do on a daily basis? And then you have a whole movement going in the community, because you've got the adults actually modeling for the children as they're implementing your strategies. And personally, I found that works a lot better than just charging adults to take care of kids. And here's just a quick aside. The study I'll talk about in a moment, called Live Well, which is a grant that followed this, focused on new immigrants in the community. And I went to a focus group that we were conducting years after Shape Up was over, probably 2 years later. And it was in a basement of a housing project in Somerville with Haitian families. And obviously they were speaking Haitian Creole, but I was getting the translation, so I knew what they were saying. And a woman came, probably in her late 50s, in a Shape Up Somerville t-shirt. And she didn't know that I'd been the PI of Shape Up, and to be honest, it didn't matter. But I was so curious to hear what she was going to say. So she starts telling this whole story, and I'm just waiting for it to be translated. And the story was, she came to the US, she gained 50 pounds, that's a little extreme, but most new immigrants gain weight when they come here. I think everyone's aware of that. And then she was working in a cafeteria in Somerville, and this study started called Shape Up Somerville. And she got really excited and wanted to learn more, and a group of them started a walking club, and they started then eating the school lunch, which became, it was this whole story, and long story short, she lost 30 pounds. And so I got to hear that story, which I never would have heard if I hadn't gone back out into the community to hear about it, but it really made me feel like it was all worthwhile, knowing that here's this woman who, and I didn't tell her that I had been with Shape Up, but it was incredibly rewarding, and I know there are many other stories like that. But the professional development and just engaging the community really does matter. And additional funding obviously always matters, but, but then ownership, and I do this a lot with my community work. I ask people to sign memorandums of agreement and understanding and contracts. It sounds detailed and almost like something that's more of a business relationship, but it really matters. people then feel accountable and they actually come through. We had dedicated staff within city government. We had a task force, which was basically a coalition that was the grassroots movement, and multiple systems within the community being involved. And then a lot of policy changes happened that are still in place today, and that's what led to the sustainability of the effort. So these are just some ingredients for sustained success. I want to just talk for a minute about a lot of the work I'm doing now with system science. And how many people in the room use system science, agent-based modeling, or a little bit? Okay, good, dynamic modeling. So the reason that I got interested in this was when the study was over, again, I took a step back, and it was really hard to do the analysis that I showed you, which is an individual nested within school, nested within community, you know, multiple regression, and really feel like I had a good understanding of what was happening in the community at large. And you remember the diagram I showed you before, during, after school? That's pretty linear. A child wakes up, they eat breakfast, they go to school, they, you know, it's a straight line of their day. But the truth is there are multiple things going on at the same time, interacting and impacting an individual, and that's true for all of you as well. And I was really searching for the right mechanism or the right discipline to help me understand what was happening within the community and the future work that I started to do. So from my perspective, using a systems-oriented approach really does require you to depart a bit from linear thinking. A very controlled experiment we've all done requires linear thinking. It's important, but you have to step away from that and allow yourself to free yourself from that thinking if you're going to move into this, even from multiple causation and independent levels of influence. So I was trained, like many of us, to use the socio-ecological model, which is excellent. It's a person or a family nested within larger settings and influences and even society at large. But it's still pretty linear when you put it like this, and even when you design studies using this as your base. And so I really had an interest in thinking differently. So I started to partner with some system scientists and develop an understanding of the whole system, which I felt was really critical in order to, one, interpret what I had done, but two, to move forward and do it even better. And so this perspective recognizes a complex, reciprocal, interdependent, and interactive relationship between the individual and their environment. And I really think it's necessary in order for us to move forward with this systemic approach to obesity prevention. And it really highlights the circumstance in which an event occurs or the context. The contextual part of this is extremely important. And most importantly, what I needed to do at that moment was really to map out the processes and mechanisms that I believed were needed to change, to alter the social relations that are damaging to health. So it was kind of a process I went through for a couple of years, trying to understand the work that I'd done and to make sure that as I moved forward and tried to replicate it, I did it even better. And so this is what a systems-oriented approach looks like. It's not A to B to C, or even having a mediator or moderator. It's much more complex. And so I started working with some system scientists to really look at the dynamics of community change and to talk about the Shape Up Somerville experience. So what actually happened in that community while we were intervening aggressively and in the years thereafter. So by the time we finished this, which was just recently, it was actually a 10-year retrospective. And we wanted to describe the key aspects and dynamics within the community and to examine this model using a systems perspective so we could create a framework that helped guide future interventions. I felt disingenuous just giving people that diagram that I showed you earlier and saying, oh, we'll plug this in with some community engagement and it's all going to be fine, because it really didn't happen like that. It was a lot more complex. So we used qualitative systems analysis, and this was informed by individual and group interviews, as well as all the process data that we had collected throughout the intervention and afterwards. And what I was really trying to do with this mapping was to illustrate through the integration of the socio-ecological model and community-based participatory research methods, which is what we used, to really visualize the entire change in the community. It's going to look really overwhelming when I show it to you, and your first reaction might be this isn't helpful at all, but keep in mind there's a narrative that goes with it that actually explains it, that's a lot more detailed, that hopefully will be published in the next year, and I'll look forward to sharing it. But it does make a lot of sense versus a linear process. So this is the dynamics of community change. And this is a systems map. It's dynamic mapping where there are feedback loops, and some are positive and some are negative. So the story isn't completely positive. There were things that happened along the way that slowed us down or that forced us to change course. And because it was community participatory work, we were hearing that, we were collecting that, and we were making adjustments. We stayed true to the evidence-based recommendations, screen time, the things that I showed you, decrease in sugar-sweetened beverages, et cetera. But the way that we got the implementation done, we had to listen to the people who were actually implementing it. So this shows the multiple systems within a community that were involved that helped us implement the strategies. And those include the school system, the food environment, the media, the family system, the built environment, the community at large, and this is the coalition, the task force. And all of this feeds into the individual and in the energy balance loop, which is energy in and energy out. And that's ultimately what we were trying to impact through all the work that was being done at the community level. So the narrative, again, describes how things happened, and then this right here is a little time meter, and it shows you changes in the built environment are very, very slow. You can't decide that a neighborhood is lacking the ability to walk and then build a bridge. That takes sometimes a decade for the funding and the policy, but you can pretty quickly make changes in the school system. That happens quite rapidly, extremely rapidly in the media. If you have a good story, it can be in press tomorrow. And the media has a big influence on the way we think as a society. So it helps people see things that have the ability to change rapidly, that you can take advantage of and leverage, and things that happen a lot slower, like the food environment. You can't decide to rely on local agriculture unless you make a big investment in planting food in the local community. Shape Up Somerville. So that was the local task force coalition that is required in any community-based work that you do. And it lives on today, and it's stronger than ever. So this project actually has had quite a bit of success post-intervention, which has been really exciting. So after this, during this whole process, after it ended, I started to try to replicate it in different environments. And the first thing I did was really went for the other extreme and tried to replicate it in rural America. Rural America is a very interesting place to work if you haven't spent time there, and desperately in need of good interventions. So I partnered with Save the Children, which does all their domestic work in rural areas of the US. And what we set out to do was adapt and implement elements of Shape Up Somerville and test for effectiveness in a rural setting. And we did use a randomized control model. And we had first through sixth grade children in 4 rural regions of the US. And we were working on the same model of individual, family, community, and school level environmental and policy outcomes. And the long-term goal was to disseminate the research to empower individuals and communities in rural environments. Could we take this urban model and make sense of it and implement it in a rural environment and see changes in environmental and policies, environmental changes and policy changes, as well as individual level changes? So we had the same outcomes on the children. So where we worked was noted here in blue, and these were 8 study sites in 4 different states, and I won't ask you what the states are because I bet you all know right away. 4 intervention and 4 control, 1 per state. And so there was a pair chosen in the state, and they were matched, and then they were randomized. So it's really hard to work in rural America. It's difficult to define geographically. Everything's county level, not local. There's entrenched poverty, population loss, low education and literacy. There's racism. We were working in communities where it was unsafe for either a black or a white individual to go into the community, and this was just a few years ago. There are less developed transportation infrastructure, so people shop primarily at Walmart, which is often 45 minutes to an hour away, and they go in frequently. So that completely cuts dairy, protein sources like chicken, fruits and vegetables from their shopping list. And it's, you know, food with a long shelf life. lack of access to health care, safety concerns, isolation and stigma. Some of the places I went really felt like I was in a third world country. So we worked in the Central Valley in LA, in the southeast area of South Carolina, in the Delta, and in Kentucky and Appalachia. Beautiful, but there's not a lot there. And even some of the farming that still goes on is primarily mechanized, so there aren't a lot of people actually working out in the fields as well. So we did a lot of formative work because we didn't know what we were getting ourselves into, although the Save the Children partners were quite helpful. So one of my former doctoral students, Erin Hennessy, who's now at NCI, led a photo voice project. And we put cameras, digital cameras, in the hands of parents and teachers, and we said, photograph your communities. And it was obviously a protocol that went along with this. Bring your photos back, and we're going to talk about it, code the themes, and really try to understand your environment and what you're living in. So I just wanted to give you a snapshot. This is a photograph taken by a mother in rural South Carolina, and it's a vacant home, and here's a quote. There's a lot of vacant houses that have a lot of drug and criminal activity going on. It's unsafe for kids. Look how close it is to the road. I don't like my kids walking by here. So you'd find this in urban settings as well, but somehow it's a lot scarier because if you're walking by there, there's no way to call for help. So it's just very isolating, and people keep their kids very, very close. And here's another one taken by a school staff member in Appalachia, Kentucky. Our kids can't walk or bike to school. Look at the road, it isn't safe. Some of these kids are coming from really far away. They spend almost an hour on the bus to get there. It's just very, very different. So I'm just going to show you a couple results from work we did there, but what I am going to tell you is it really is hard to be a community-based intervention because there's no community infrastructure. It ends up being school-based. And as best you can, outreach to the home. But the school is really the hub in rural America. It's where most people work, if they do work. It's where the kids spend a lot of their time. And it's where environmental and policy changes are possible. And so this is a result of our food service intervention. And I just wanted you to get a sense of the communities in California, Kentucky, Mississippi, and South Carolina. Here are the children in those schools that were eligible for free or reduced price lunch, so the majority of children. And it just gives you a sense. They're all on-site food service delivery, so they were actually making quite a bit of food on site. And you can see the population breakdown where primarily white in Kentucky and African American in Mississippi and South Carolina and Hispanic in California. So we had an ethnicity variable that we had to account for. Aside from that, there were a lot of similarities in these communities. So when we implemented the food service part, we actually had an impact on whole grains. So we were able to change whole grains, and that's in large part due to the food service system in this country that's able to get whole grains now into products like obviously bread, but pasta and cereals, and they're a lot more palatable than they were in the past because sometimes they even look like white bread, for example. So we were successfully able to change whole grains and decrease the refined grains and the offerings of whole grains. And so that looks promising. You're able to change the food supply to the children, but the question was, are they actually eating any different in the school and out of the school? So we have some consumption data as well, and we've published this. And what we saw in this case was there was a change in the glycemic index of the food that they were consuming, which is positive and related to the whole grains probably, although we didn't pick up a difference in fiber. And then most importantly, we saw an increase in fruits and vegetables, which was pretty exciting. And this was 24 hours, so it was probably a combination of what they got in school and hopefully what they were getting in after school and at home. So this was pretty positive in a very tough environment to actually see a dietary change at the individual level. A lot more work needs to be done in order to do a much more robust intervention, but I can tell you that almost 50% of the kids were already overweight and obese in elementary school. So I would say we need more healthcare treatment than we do prevention in these communities, because if you're going to work on prevention, it has to be 0 to 5. By the time they get to elementary school, we had plenty of kids in the study who were, 4 feet 6 inches, 200 pounds. So there's a extreme obesity, and about 85% of the adults that we worked with and did direct measurement with were overweight and obese, compared to 66% nationally. So very difficult communities to work in. So Live Well was a result of Shape Up Somerville. When I looked at some of the data we'd collected, we saw that children who were born to immigrant mothers were gaining weight more rapidly. And we looked in the control communities to get a sense of that, because the intervention obviously would have contaminated the ability to look at that. So we'd already been working with the ethnic groups in Somerville, and we saw that they were quite hard to reach and disadvantaged, and we wanted to get a better sense of how change could occur in these communities. So this was an NIH grant. It was community-based. It was randomized. So it was randomized at the dyad level, so mother-children. And we designed an appropriately timed intervention, hoping that we could prevent excess weight gain in newly arrived immigrant mothers. And because we were working in Somerville, the primary immigrant populations are from Brazil, Haiti, and Latin America. So we targeted mothers who'd been here. Actually, it started out based on national data. We do know from NHANES the most rapid weight gain occurs within the first 7 years when new immigrants come. It's very hard to recruit new immigrants because they're fearful, obviously, of a lot. But signing an informed consent and giving a lot of information became challenging. So we had to loosen the recruitment criteria and go to less than 10 years in the US. They had to have a child between 3 and 12 coming from one of these countries. And again, it was funded by the NIH. And this is really the model, focusing on the disruption in energy balance that occurs when people arrive in the US. That's because it's an obesogenic environment for all of us. It's because there's a lot of stress for new immigrants. There's a lot of isolation, and they're lacking in basic nutrition education. And many of them had no formal education. So this disruption, of course, leads to weight gain, which leads to obesity. So we looked at 383 mother-child dyads. They had children about the age of 6, and about 43% were overweight and obese of the children. And in terms of the mothers, they were about 36 years of age. They'd been here an average of 6 years. 31% had less than a high school degree. You see the breakdown was pretty good in terms of the distribution, which we wanted, and 72% were already overweight or obese. So we're working on the outcome data right now, so I don't have that to show you. This just ended, but I do want to show you some of the formative work we did, which helped us design the intervention, because you couldn't just take an off-the-shelf curriculum and try to implement it with these moms and children. So this just gives you a sense of how some of the behaviors differed in the US versus their home country. So we looked at food availability and dietary habits. They all said food in their home country was cheaper, hands down. They had a lot more time to shop and prepare food, and that there was far more diversity of food in the US, which was quite overwhelming to most of them. And here's a quote: "In our countries, things are more natural. The food in our countries is grown from our own hands, and here these machines and the procedures to get food are different." So they really see it as highly processed, which is true. In terms of physical activity and exercise, there's more work-related activity in the US, but they didn't perceive it as physical activity. And one of my doctoral students is working on these data right now, and we certainly don't want the headline to be, well, new immigrants get plenty of moderate to vigorous physical activity. The way they're getting it is often quite dangerous, whether it's cleaning homes with exposure to toxins, or whether it's working in a factory where they might be moving, but it's really not high quality physical activity. So we're being very careful about it, because the truth is some of them do get a decent amount of moderate to vigorous physical activity. And there's weather barriers compared to some of these southern climates they came from. Here's a quote: "But I believe that it does not make you move a lot, house cleaning. Many people say that cleaning is a physical activity, but it seems to me that it's not the same than if you go to the gym." In terms of sleep habits and time management, women don't sleep as well here due to stress, busy schedules. They feel like they have less control of their time when they move to the US. And then the child care arrangements and school-related activities and services are far more stressful. So they're living pretty challenging lives. In Haiti, people like being together. For example, on Sunday, you go to church, you prepare food, you stay at the table, and here it's work, work, work. So this is not surprising to you, but we had to gear the intervention to their lives, and their lives are quite different, and there were a lot of other subtleties that we picked up on that we incorporated into the curriculum that we designed to work with them. So putting all this together, I wrote something with Allison a couple years ago that really my thoughts and Allison's thoughts based on our own work and what we gathered from the literature to be required elements to advance community-based research approaches to address obesity. I definitely think we have to take a systems approach, and the work I'm doing now, I am using agent-based modeling to inform the work I'm doing, and it's rigorous and exciting, and I'm really finding it to be a lot more fulfilling because you're working with data to actually model and predict what you should do. It's not perfect, but it's definitely useful. We need to train future leaders in community research methodology and social change. A lot of people learn it once they get out and do the research, but interdisciplinary work really requires interdisciplinary training, and I think we need to do a better job, particularly with nutrition scientists, applying transdisciplinary strategies, funding to conduct rigorous trials to determine efficacy and effectiveness. You know, I showed you some data today, but I really try as best I can to get direct measures. I do survey work as well, but you know, I've done DEXA, I've drawn blood, I get direct measure of height and weight, 24-hour recalls, accelerometry, as best I can, so I have the more rigorous measurements that I can be reporting as a result. Enhanced design and analysis approaches. This requires a lot of collaboration with biostatisticians and epidemiologists. New and improved tools and methodologies to collect quantitative and qualitative data. Examples obviously are focus groups and key informant interviews, photo voice, community readiness, which I use, community mapping and modeling. Bringing all this together is important. Improved community engagement models, that's a science in itself. You're not just talking to people. Engagement and engagement science is a really interesting area. Sustainability frameworks. We started Somerville, and about 1 year into it, we started designing a sustainability framework because I didn't want to go into a community, do some great work, and then leave with my staff and my money and my ideas, or our ideas. And that was really important because the project lived on. And as you know, if you've worked in the community, people are fearful. Here come the researchers with their money and all they want are data, and then they're going to leave and it's going to be over. So helping them with sustainability frameworks is really our responsibility. Advancement of a bold public policy agenda. I've been working a lot with the Institute of Medicine and producing a lot of reports on obesity prevention, and I think it's becoming a pretty substantial agenda now, and with the First Lady taking it on, it's gotten more attention. Including economic analysis, I'm probably most excited about my current work where I'm using cost effectiveness and return on investment, because it's a lot of money that I have been given over the past 15 years to do this work, millions and millions of dollars, like many of you, and then you try to bring it to the community and scale it. Well, what does it cost? And is it cost effective? So I'm doing a lot of that with health economists. Obviously, that's not my training, but it's really exciting because it helps you with your decision making. Is this the right thing to scale up or not? And if it's not, you shouldn't do it, because no one has millions of dollars to be putting into interventions for children right now. So we have to be smart and flexible and nimble as we move forward. And lastly, acknowledgement of the approach as viable. When I first started doing this work, I definitely sensed a lot of pulling away. You know, you're leaving the laboratory. I was trained in basic science. You're going to work in the community. You're never going to get good data. You know, you're never going to be a good scientist. But I think that a lot of people who do community-based work and try to maintain the rigor, you know, have been quite successful. So that would be my recommendation, to make sure that we continue to hold up community-based research as a viable and important type of research to do. Can I ask for a time check?
12:55.
Yeah. We don't?
No.
Oh.
What I was going to say, someone's going to do one.
Okay, can I do 5 minutes? Or no?
Probably not able to set up.
Oh.
Maybe like one.
Okay, okay.
Everyone that comes to our lunch.
Okay, okay, yeah. So I said my talk was too ambitious, and it was, because there was more I wanted to talk about with my current work, but I'm going to give 10 seconds on it. It's national scale up of a lot of this work. It's called Child Obesity 180, and it's blending the rigor of science and the evidence base we have with the innovation of business. And the reason I think it's pretty exciting is the business world knows how to scale pretty quickly. If they have a product they want to take to market, they can do it. If we have a product we want to take to millions of people, we struggle with that because we're not trained to do it. So we're kind of combining those strategies and trying to get a lot of this work to children nationwide, and that's why I'm doing a lot of cost effectiveness modeling. Thanks. So I'd love to take a question, and happy to, you know where to find me at Tufts if you have additional questions. No? Okay, yeah.
I was interested in hearing a little bit more about the intervention for I think it was
Live well, sure, yeah.
Especially because
Yep.
there's so many different ethnic groups,
Yeah, yeah.
languages.
Great. I'm glad you asked. Yep. So it was delivered by ethnic group, by someone who spoke the language. The entire curriculum was similar, and it was developed using popular education and social learning theory. So we kind of infused the two together. So again, the evidence, the evidence-based information we were delivering was the same. And it was developed with their input, so a lot of it was experiential lessons. It was really hands-on, and it was delivered in 2 ways. 6 of the 12 sessions were group, and they were small groups, 6 to 10 women with a facilitator. And 6 of the 12 were individual using motivational interviewing. And a coordinator tracked each individual woman. So each of the coordinators had about 110, 120, 30 people under them that they were working with in small groups and through motivational interviewing. So that was how it was delivered. And that really was designed, again, based on a lot of formative work we did. They wanted some group work, and then they wanted some individual work. The group work was what they loved the most. Yeah. Okay, good. Thank you.